Drugs to treat infection, antibiotics. At the end of this, students should be able to describe the various types of antimicrobial medications, describe the mechanism of action for antibiotic medications, list general considerations of antibiotic use and people at risk for bacterial infections, recognize clinical manifestations of bacterial infections, identify clinical scenarios in which use of bacterial agents is inappropriate, and collaborate with prescribers and other healthcare providers on antibiotic misuse and stewardship. Antimicrobial agents have been a major influence on human health. Together with vaccines, antimicrobials have contributed to reduce mortality, extend lifespans, and enhance quality of life. However, antimicrobial drugs must be used with caution because they promote the occurrence of drug resistance in both the pathogens they are designed to treat and in other bystander organisms. Antibiotics are prescribed to approximately 1/3 of all hospitalized patients and account for greater than 10% of hospital pharmacy expenditures. Up to half of the antibiotic orders may be unnecessary, poorly chosen, or dosed incorrectly. The overuse of antibiotics has led to decreases in their effectiveness and the emergence of superbugs, also called multi-drug resistant organisms, or MDROs. These are strains of bacteria that have developed resistance to many different types of antibiotics. The following bacteria are examples of MDROs: methicillin-resistant Staphylococcus aureus, or MRSA, Pseudomonas aeruginosa, and vancomycin-resistant Enterococcus, or VRE. Of great concern is the new strains of bacteria that may emerge that cannot be treated by any existing antibiotics. Antibiotics are used to treat or prevent infections by pathogens, specifically bacterial infections. They are not effective against viral infections such as the common cold or influenza. Bactericides kill bacteria. Bacteriostatics slow the growth or stall the growth of bacteria. Non-antibiotics are also known as antivirals, antifungals, or antiparasitics. These are medications that do not treat bacterial infections but are critical to treating other microorganisms. Bacteria are classified by the following: their morphology or their shape. They can be classified by spheres, cocci, rods, bacilli, and spheres, and spirals or helix, also known as spiralets. We can also classify them by their gram staining. This is a bacteriology laboratory technique that is used to differentiate bacterial species into gram-positive and gram-negative groups based on the physical properties of their cell walls. Encapsulation. Encapsulated bacteria are protected from ingestion by phagocytes, thereby increasing their bacterial virulence. Oxygen requirements. Aerobic bacteria require oxygen to produce energy and grow in culture, whereas anaerobic bacteria do not require oxygen and do not grow in culture if air is present. Anaerobic bacteria are common in the gastrointestinal tract, vagina, dental crevices, and chronic wounds when blood supply is impaired. These bacteria occur naturally and are the most common flora in the body. In their natural state, they do not cause infection. However, they can cause infection after an injury or trauma to the body. This is figure 10.2. This figure illustrates the different shapes of bacteria. Antibiotics have many mechanisms of action. They can inhibit the cell wall, the synthesis. This includes the inhibition of cell wall synthesis, which is the most common mechanism. We can also inhibit the protein synthesis, which is the second largest class, alteration of cell membrane structures, inhibition of the nucleic acid synthesis, and anti-metabolic activity. The picture at the bottom right is figure 10.3. This is the mechanism of action of the antibiotics on the bacterial cells. Antimicrobials vary in their ability to inhibit or kill different species of bacteria. Antimicrobials that kill many different species of bacteria are broad-spectrum antimicrobials, whereas those that kill very few different species of bacteria are narrow-spectrum antimicrobials. Broad-spectrum antimicrobial coverage increases the likelihood of empirically treating a causative pathogen. Unfortunately, secondary infections caused by certain antimicrobial resistant pathogens commonly develop. Although there are hundreds of different types of antibiotics, many are structurally related and thus grouped into classes. Drugs with each class share structural and functional similarities, although they often have different pharmacology and spectra of activity. Most antibiotics can be classed into specific groups based on their mechanism of action and their spectrum of bacterial site activity. Some drugs inhibit cell wall synthesis, while others inhibit protein synthesis. Still others will inhibit nucleic acid synthesis, while others alter the cell membrane, and others are antimetabolic. Table 10.1 illustrates the mechanism of action of antibiotic drugs, the spectrum of antibacterial activity, and the therapeutic indications of these drugs. The routes of administration. Most antibiotics prescribed to patients are delivered via the enteral or gastrointestinal route. These are typically in the form of pills, tablets, or capsules, and occasionally are liquid. Patients with a functioning gastrointestinal tract and without hemodynamic instability may receive oral antibiotics, especially if the agent has good bioavailability. However, patients manifesting systemic signs of infections, such as hypotension or hyperperfusion, should receive IV or intravenous antibacterials. Antibacterials with poor bioavailability should be administered intravenously for systemic infections. IV administration of orally available drugs is preferred in the following circumstances: if oral antibiotic drugs cannot be tolerated, if oral antibiotics are poorly absorbed, because of malabsorption after intestinal surgery, impaired intestinal motility, such as due to opioid use, or if the patient is critically ill, requiring the most immediate medication effect or possibly having impaired GI tract perfusion. Osteomyelitis, a bone infection, is a serious complication of a compound fracture. When the infection is diagnosed, an early option is an IV of antibiotics. A variation of IV therapy is to use a peripherally inserted central catheter, also known as a PICC line, to administer antibiotics directly into the systemic circulation. Although the use of a PICC line has potential complications, it is useful for administering higher concentrations of medication. Measuring the C-reactive proteins, or CRP, level and repeating images is recommended as follow-up to the initial diagnosis. The pharmacokinetics. Many factors can affect the antibiotic drug's absorption, including the timing of food consumption relative to drug administration, drug metabolizing enzymes, or underlying conditions such as diarrhea or illness that can affect the site of drug absorption and therefore alter bioavailability. Certain orally administered drugs have lower bioavailability because of the first-pass effect, the process by which drugs are absorbed in the small intestine through the hepatic portal circulation and then directly transported to the liver for metabolism. Antibacterial drugs are distributed by binding to serum proteins, and a given drug is usually described as either poorly or highly protein-bound. Only the unbound free drug is active and available to exert antibacterial effects. Like many drugs, antibiotics are metabolized by the cytochrome P450 enzyme system in the liver. For excretions, approximately 5 to 7 half-lives are required for an antibacterial drug to reach steady state when multiple doses are given in a time frame shorter than the half-life itself. The pharmacodynamics. 4 important pharmacodynamic parameters are related to antibacterial efficiency. Minimal inhibitory concentration. This is the lowest drug concentration that inhibits the growth of a microorganism under standardized laboratory conditions. The peak to minimal inhibitory concentration, or MIC ratio. This is best correlated with antibacterial activity. The ratio of peak serum concentration to the minimal inhibitory concentration, or the magnitude to which the peak concentration exceeds the minimal inhibitory concentration. The percentage of time above the minimal inhibitory concentration, or MIC. This is the duration of dosing interval in which the antibiotic concentration exceeds the minimal inhibitory concentration, or MIC, that best correlates with the antibacterial activity. The 24-hour area under the concentration time curve. This concentration time is compared to the minimal inhibitory concentration to create a ratio that best correlates with the antibacterial activity. The image on the right is figure 10.5. This is the time versus the concentration of a single dose of a theoretical antibiotic. The dosing guidelines. The timing of the initial therapy should be guided by the urgency and the severity of the patient's condition. For patients with severe illnesses, a common approach is to use broad-spectrum antibacterial agents as the initial therapy. The intent is to cover multiple possible pathogens commonly associated with the specific clinical syndrome to ensure adequate treatment of possible pathogens while additional data is being collected. It is important to understand that patients should take a full course of antibiotics, even if the symptoms have already resolved. Antibacterial medications are among the most commonly prescribed drugs in the world and are used for a wide range of infections. However, antibiotics also expose people to the risk of adverse effects. Some side effects are common and to be expected, such as antibiotic-induced diarrhea. Other adverse effects are uncommon. Athletic trainers should be aware of a few rare adverse effects that manifest, specifically in the athletic population, such as the relationship between ciprofloxacin and tendon injury. Some of the antibiotics have specific instructions that improve the effectiveness of the medication. For example, ciprofloxacin should not be taken with calcium-rich foods like dairy or antacids. With some antibiotics, the athletic trainer should be aware of common specific instructions that clinical pharmacists provide to the patient, such as how tetracycline causes sensitivity to the sun. The indications and precautions. Although antibiotics are no longer routinely used to treat certain infections, antibiotic therapy is appropriate for some conditions. Prescribers should holistically assess the patient and provide antibiotics for conditions that meet the following criteria. These are conditions that are not serious but unlikely to clear up without antibiotics, such as acne. Not serious but could spread to other people if not promptly treated, such as the common skin infection impetigo, or common foodborne illnesses such as salmonella. Other infections supported by evidence suggesting that antibiotics could significantly speed up recovery, such as kidney infections, and any infection that is high risk of more serious complications, such as cellulitis or pneumonia. Antibiotic medications may be recommended for people who are more vulnerable to harmful effects of bacterial infections, including the following individuals: any patients over 75 years of age, individuals with heart failure, individuals who have taken insulin for diabetes, or individuals who have weakened immune systems, either by underlying health conditions such as HIV or other side effects of certain treatments such as chemotherapy. A penicillin allergy, immunologically mediated adverse reactions to beta-lactam antibiotics in about 10% of patients receiving that agent, whereas anaphylaxis occurs in about 0.01% of patients. Patients who claim to have a penicillin allergy may not really have a true penicillin allergy, although the cross-reactivity between penicillin allergy and cephalosporins is extremely low, less than 1%. Infrequent adverse hypersensitivity effects include fever, vomiting, arrhythmia, dermatitis, angioedema, and pseudomembranous colitis. Macrolides. This group of medication, which includes erythromycin, clarithromycin, clarithromycin, and azithromycin, is among the most commonly prescribed class of antibiotics worldwide and is used for a wide range of infections. In a systemic review from the Cochrane Library, most studies, about 89%, reported at least some adverse events with the use of macrolides, with GI adverse events the most commonly reported. Erythromycin caused GI side effects in a significant portion of patients. Other macrolides have been developed that produce fewer side effects and are more easily absorbed. Tetracyclines were discovered in the 1940s. They exhibit broad-spectrum activity against a wide range of microorganisms, including gram-positive and gram-negative bacteria, rather than killing the infectious agent, such as a bacterial side. Tetracyclines inhibit bacterial growth, a bacteriostatic, and are effective only against multiplying microorganisms. The widespread use of tetracyclines is thought to have contributed to an increase in the number of tetracycline-resistant organisms, in turn rendering certain infections more resistant to treatment. C. difficile-associated diarrhea, CDAD, has been observed greater than 2 months post-antibiotic treatment. Tetracyclines are likely to cause photosensitivity, and patients taking this medication should use skin protection and avoid prolonged exposure to sunlight and ultraviolet light. Tetracyclines include doxycycline, a common drug used to treat a wide range of infections, and minocycline, a common drug used to treat respiratory and other infections. Fluoroquinolines. The fluoroquinolines are a group of broad-spectrum, bactericidal antibiotics that are effective against both gram-negative and gram-positive bacteria. A common prototype fluoroquinoline is ciprofloxacin, also known as Cipro. This is one of the most widely used antibiotics around the world. Other examples of fluoroquinolines are levofloxacin and oflafloxacin. Ciprofloxacin is commonly administered by team physicians for upper respiratory tract infections and sinus infections and has gained notoriety in 2001 relating to concerns about widespread anthrax poisoning in the United States. An unusual potential adverse effect associated with ciprofloxacin is its link to tendon pathology, including tendinitis and tendon rupture. Concomitant with administration of corticosteroids may potentiate the risk of tendinitis and tendon rupture associated with fluoroquinoline treatment. To prevent a tendon-related adverse effect secondary to fluoroquinoline use, these antibiotics should only be used to treat conditions that are proven or strongly suspected to be caused by bacteria, and only if the benefits outweigh the risk. When working with patients taking fluoroquinolines, at the onset of tendon pain, athletic trainers should reduce the patient's exercise, consult with the prescriber, and exclude eccentric exercises from the rehabilitation program during the course of medication. The symptoms of fluoroquinoline-induced tendon injury may be present within hours of starting the antibiotic treatment and continue for up to 6 months after it has ceased. Although patients older than 60 years bear a greater risk, tendinopathy has been reported by people as young as 18 years of age. In general, patient education for antibiotics is similar to that of most commonly prescribed antibacterial medications. It is important that patients understand that they may experience some abdominal pain, nausea, vomiting, and diarrhea. It is important to remind patients that extended-release tablets need to be swallowed whole and not split up or broken. It is important to remind patients that doses should not be skipped. Photosensitivity may be possible with selected antibiotics. Some red flag signs mandating that the athlete should contact their provider include tachycardia or an abnormal heartbeat, the patient fainting or having syncope episodes, difficulty breathing, hearing or vision changes, dark urine or light-colored stools, or jaundice. The collateral damage. Collateral damage refers to the development of the resistance occurring in a patient's non-targeted antibacterial flora or microbiome that may cause a secondary infection. For example, clindamycin may be used to treat gram-positive cocci infections. However, this drug also readily selects for resistance in C. difficile, a non-targeted organism that may be present in the GI tract. Patients with diarrhea and indications of fever, abdominal pain, or frequent loose, watery, or bloody stools require prompt referral to the prescriber or urgent care. The major problem threatening the continued success of antibacterial drugs is the development of resistant organisms. Antibiotic-resistant mechanisms have existed long before the clinical use of antibiotics, even resist to the synthetic drugs that were created in the 20th century. Because resistance mechanisms are already present in nature, an inevitable consequence of antibacterial use is the selection of resistant microorganisms. Since the start of the antibiotic era, antibiotic use in patients and animals has fueled a major increase in the prevalence of drug-resistant pathogens. The Centers for Disease Control and Prevention estimates that every year in the United States, at least 2 million people acquire and 23,000 people die from infections caused by resistant bacteria. Prescribers are more discerning regarding treating infections with antibiotics because of the following. Many infections are caused by viruses, so antibiotics are not effective. Antibiotics are also unlikely to speed up the healing process and can cause side effects. And more often, antibiotics are used to treat trivial conditions, the more likely they are to become ineffective for treating more serious medical conditions. Athletic trainers can help educate patients and parents on the appropriate antibiotic use, which can improve their health literacy and augment efforts to improve antibiotic use. Helping to collaborate with prescribers and pharmacists' oversight, the athletic trainer and other healthcare providers can do the following. We can use effective communication strategies to educate patients about their antibiotics, what they are for, and when they are not needed. We can help educate patients about the potential harms of antibiotic treatment, and we can provide educational materials. In summary, athletic trainers should help make appropriate medical referrals. We can educate patients on best practices related to pathogens and data, and help to reduce the risks of antibiotic-resistant bacteria, and help to educate individuals that shorter courses of prescriptions may be better than longer courses. The prescriber should choose the prescription and duration based on the nature of the infection and the patient response.